Hello everyone. Today let's discuss about an important topic named as distal femur fractures. So basically condylar fractures of the femur are divided into three types. They are supracondylar, intercondylar as well as unicondylar. Intercondylar are further divided into T-shape as well as Y-shaped. These fractures often result from direct trauma to the lower end of the femur. Indirect forces more often result in unicondylar fractures. Either valgus or varus bending force can lead to unicondylar fractures. Supracondylar fractures often result due to hyperextension force. So this is a supracondylar fracture where you can see a fracture is seen above the condyles. This is an intercondylar fracture which is further divided into T-shape as well as Y-shape. Whereas unicondylar fractures involve either a medial condyle or lateral condyle. Okay, so basically supracondylar fractures and intercondylar fractures of the distal femur are highly unstable. They are often comminuted and often difficult to treat. You can see this is high incidence seen among women more than 75 years of age group and adolescent boys and men ranging between 15 to 24 years of age. As these fractures are in close proximity to the knee joint, regaining back the knee motion and function is often difficult, and there is high chance of incidence of infection. Non-union or malunion are very high with these type of fractures. The classification of the distal femur is described by Muller and expanded by AO or OTA classification. This classification is useful for determining the treatment options. So here you can observe that this is the Muller's classification. So it is divided further into A, B as well as C. In type A, you can see it is further divided into A1, A2 and A3. B is further divided into B1, B2 and B3. C, C1, C2 and C3. Type A is usually, this is type A. So this type A is usually extra-articular. Type B is partially articular and type C is completely articular. Further, in type A is divided into A1, A2 and A3. In type A1, you can see that the condylar usually involving only involving the distal shaft. So it is further divided into A, B as well as C. The distal shaft only with varying degree of comminution. In type B, you can see that B1 further divided into B1, B2 and B3. B1 is sagittal split fracture of the lateral condyle. So here you can observe that only lateral condyle is involved. In type B2, you can see that medial condyle is involved. In type B3, you can see coronal fracture pattern is seen. In type C, it is completely articular. Articular surface is completely involved. It is further divided into C1, C2 and C3. In C1, you can observe that there is no comminution. In C2, you can observe that it is associated with shaft comminution. Whereas C3, you can observe that there is intra-articular comminution. Further, the treatment options, if it is a simple undisplaced fracture, long leg cast is usually given. For unicondylar fracture, immobilization is done for 3 to 6 weeks, and after 3 to 6 weeks you will do careful weight bearing. Then comes this early mobilization of the knee is important for good results. Next comes the surgical options. Surgical options include plate with screw fixation. Usually blade plates with screw fixation, it was previously used. Although provides stable fixation for most of the fractures, complications like infection, inadequate fixation in osteoporotic bone, increased chances of refractures are more common after plate removal. As experienced with the AO, plating has been increased and increased usage of peri-operative antibiotics became more active. However, obtained good results in 81% of the fracture patterns. And with these plate with screw fixation, only 7.7% of reported infections, 7.6% reported unintentional shortening and 5.8% reported malalignment. As more biological techniques have been advanced, indirect reduction techniques and minimal soft tissue stripping and also with gentle retraction, plating has become more advanced. Next comes option is dynamic condylar screw fixation. The prerequisite for dynamic condylar screw fixation is a minimum of 4 centimeters of bone in the intercondylar area should be intact above the to keep the DCS. So here you can observe that this is dynamic condylar screw fixation. Here at least 4 centimeters of the bone should be in contact above the intercondylar notch. But the main disadvantage of this is for insertion of lag screw requires removal of large amount of bone. Bone graft was used in 1/3 of fracture patterns. Not suitable for patients with osteoporosis. It is also unsuitable for less than 3 to 4 centimeters of intercondylar contact area and extensive articular comminution. In such cases, we commonly use condylar buttress plates. So, most important feature regarding this dynamic condylar screw fixation is at least 4 centimeters of intercondylar bone should be in contact to keep this dynamic condylar screw. If there is severe comminution, this dynamic condylar screw plate fixation is usually not used. We commonly use buttress condylar plate. Next option is intramedullary nailing. So they are basically divided into two types: antegrade nailing, retrograde nailing. Popular in treating type A and type B supracondylar fractures inserted through intercondylar notch. Through retrograde nail is usually inserted through intercondylar notch. Retrograde nailing is usually preferred in obese patients, used in stabilizing the distal femur fractures associated with ipsilateral hip fracture. Next comes is complications. Complications associated with distal femur fractures are most commonly associated with stiffness, osteoporosis and malunion. Stiffness due to dense intra and periarticular adhesions. If the adhesions have been formed, if a patient is having difficulty in doing knee ROM, then arthrolysis is also performed in certain cases. Osteoporosis can occur in later part of life in malunion. I hope you like the video. Enjoy. Take care. Bye-bye.